can everybody hear me okay and see the slides? Yes?
Yeah, brilliant. Thank you.
Oh, that's great. So, okay, so myself and John Moriarty are here today to talk to you about the results that we are analysing currently that are emerging from the second survey of 3, with the focus of health and social care workers, quality of working life and coping while working during the COVID-19 pandemic. We'll also reflect on the results that we collected from May to July 2020. There will be a third survey and it'll be from May to July 2021. So we will cover a full year really of what the experiences have been for health and social care workers working during the pandemic. I'm just acknowledging our colleagues on the first slide. So this is a project that is shared between ourselves at Ulster and Queen's University, King's College London and Bath Spa. So the background and methods. So basically what we aim to do is to give an opportunity for people from these professions working during the pandemic. So nurses, midwives, allied health professionals, social care workers and social workers. And we have these specific professions because we can reflect that from our research team. So we have knowledge and the practice from you know, the people that are within the team. You know, there's a number of us that are registered social workers or nurses. So also the main method that we used is an online questionnaire. We also have done focus groups, so we're analysing the data from that as well. Focus groups with managers and focus groups with frontline practitioners from across the professions. The measures in the survey that we used, so we have measured demographic information. We have measured well-being using standardised scale, short work Edinburgh scale. We have measured work-related quality of life, which looks at stress at work, control at work, homework interface, general working conditions, and job and career satisfaction. We used 2 coping scales. One is the brief cope, and the other one is Clark's coping with work and family stressors scale. And we used qualitative open-ended questions at both data collection points for the survey as well. Additionally, this time we've also introduced a burnout survey. So we will be sharing some of our results from that as well. So the demographics from the May to July time point, after dealing with missing data, we had 3,290 participants. They were mostly female, and the age range of most of the people that participated was between 30 and 59 years old. A quarter were band 6 pay band, which is the pay band that social workers would be on beyond their assessed year in employment. Most worked in the community, but that was 55%. So it's only marginally more really, because that means 45% were from the acute sector. Most worked with older people or older adults. So the demographics again, just at the November to the end of January, we were, quite overwhelmed that we got such a big response. We got almost 4,000 responses during a really critically busy time, with this surge that we've just recently witnessed. When we dealt with missing data, there was 3,499, so nearly 3,500 people took the time to participate in the survey during this really busy period. They were mostly female again, and again, the age band 30 to 59. A third of them this time were band 6 level employees. You had marginally more in the community, 52.1%, and the remainder in the acute sector. The majority were statutory employees at both data collection points, so working for NHS or health and social care trusts. So the number of responses per country, I'm just going to try and move the screen down a wee bit so as I can see my figures, but the majority of the responses came from Northern Ireland, Wales, that was closely followed by Wales, then England, and then Scotland. So you can see that we had 214 nursing staff from Northern Ireland, 64 midwives, 311 AHPs, 263 social care workers, and 337 social workers. And you can see the distribution across the other countries. So the next slide will just give you maybe a bit of a visual, a better visual of the distribution across countries. So for Northern Ireland, there was 1,189 participants, which was the most across the 4 countries. Wales, 1,095, England, 756, and Scotland, 459. The number of responses per occupational group. So social care workers are in the lead with this. So, that is really important, because this gives voice to that social care workforce. And this was really critical just in terms of the qualitative responses that they have given us, as well as the quant. And we're, drilling into some of the analysis around that. Social workers, there was 1,172. Nursing, 361. Midwifery, we struggled the first time and second time to get, a bigger sample size. So we just had 75 midwives, but AHPs, we had a good number of AHPs at 638. So at the first data collection point, we didn't ask, when we analyzed the data, we could see that there was 3 groups. There was a group that were overwhelmed. They were really expressing high levels of stress, anxiety. They were, making, statements about how difficult it was and how they were really struggling to cope. Then there was a second group that were impacted, but not significantly. So that those were people maybe on the periphery of the services that were overwhelmed, and they were getting some vicarious stress from it, but they weren't, it wasn't direct stress. And then there was a smaller group who weren't impacted by the pressures. So this time when we were running the survey, we asked the question of these 3 categories, which do you think you identify with? And this is the spread from that. So you can see there's a very small number, only 4% didn't feel impacted by the pandemic. The rest of them, 49%, were impacted but not significantly, and 47% were overwhelmed by the increased pressures. So we use these groupings then to do some of our analysis using those scales that I mentioned. So these are just an example of 3 quotes that we have just taken from the qualitative data that will give you some insight into what those 3 groups are saying. For some people, from that blue, the unaffected, they still felt that their job was really important, and that one of these responses here just gives you an example of somebody feeling that their work gave them stability and an ability to cope with the pandemic in general, and felt it was a positive for their mental health. The people in the overwhelmed category talked about weariness, stress, anxiety, and a significant impact on their well-being. And those on the periphery still talked about levels of stress, but also talked about being recognised for their hard work and appreciated. And that quote there is from a social care worker. So ways of coping, right? So we measured these at the both time points, and we're just giving you a side-by-side example of the change between May and November for these different ways of coping. Active coping and planning and positive reframing and acceptance were the most frequently used coping strategies. We found that the positive coping strategies had reduced during the second phase, during that later surge, that November to January period. And so you can see the kind of range of different average scores that, you know, people across the two different time points. It's quite stark of a difference there. But just to drill into that a little bit further, we used another statistical analysis methodology, multiple regression analysis, and that really was able to tell us what created a positive outcome or a negative outcome for people. Positive coping strategies such as active coping, positive reframing, acceptance, and exercise were all associated with higher mental well-being, better quality of working life, and lower burnout scores. Whereas negative coping strategies, venting, substance use, and self-blame were associated with lower mental well-being, worse quality of working life, and higher burnout scores. So we have, more analysis that we're working on. There's just so many questions we can ask of the data. So I am going to hand over now to John Moriarty, my colleague, Dr. John Moriarty from Queen's University in Belfast, who is going to take us through the remainder of the slides. So John, I will move these slides for you. Just go on to this one.
Great, thanks, Paula. Yeah, so I'm John Moriarty. I work in Queen's in the sociology department. I'm a former social care worker as well. So I just wanted to say thank you very much if you are one of the respondents who completed the surveys, and double and triple thank you if you encouraged your colleagues or your friends to follow the link. As Paula just said, the vivid description of experience that comes through, this is mostly numerical based sort of summary that we're going to be giving, but the voice and the typed responses that we've kind of spent the last couple of weeks working our way through is going to be a huge part of what we report back. And just to have that diversity of experience and clarity of experience coming through from social care and social workers, it's quite moving to read, and quite really important in terms of putting forward the perspective of yourselves. So I'm starting with the Wellbeing scale scores. Basically, to contextualize the numbers on the bars there, a sort of a normal or kind of an unconcerning level of well-being would be pitched at around 23 on this scale. And as you start to decline from that point, you're starting to see greater likelihood of problematic suffering, instances of depression, diagnoses around anxiety, and so on. So as you'll see, referring back to the first survey we did and forward to the one that we've just completed in January, you've pretty much all occupational groups at both time points lagging significantly below that norm that you'd expect in terms of an average for the overall population. So it is worth saying we've done surveys. Some of you might have heard us do seminars on them before, where we know that going into the pandemic we had issues where there was diversity and a lot of variation in levels of well-being in some of these occupations. So it's in some ways unsurprising that that would endure, and seems to be worsening to an extent as we carry on through the pandemic. So we have we see a reduction from time one to time two for nursing, for midwifery, for allied health, and social care has almost the largest single reduction, or is very close to nursing in the magnitude of the decline there. And it's a similar story for social work. And yeah, as I say, it really triangulates well with what we see in terms of what people are describing, the sort of emotional labor impact, the magnitude of demands, the variety of demands, the different case mix that people are having to deal with and having to learn on the job at speed in a lot of instances. So we're seeing that wash out in reduced overall well-being. As Paula said, we are drilling into, we did get a slightly different response pattern where we managed to pick up extra responses in areas that we weren't able to as well in the May-June period. So when we produce the final report, we will have sort of kind of adjusted for some of that noise. But I think there's almost no doubt that we'll see, a clear signal that the duration of the sort of emergency state of social services is having a direct impact on well-being. And I should note as well that this is we'll get in the next couple of slides, we'll get into work-related specific questions that we asked about, but it came through as well from a lot of those responses that people are living through this pandemic the same as every other citizen is living through it, and there's a different pattern of demands and experiences and different challenges to well-being. But I think it's sometimes underplayed in the narrative about the impact on frontline workers, the fact that a lot of the same instances of bereavement, instances of needing to homeschool, coping with lockdown, sensations of isolation, closure of services, disruption to routine. So the same kind of release and comforts that people would get to use to bolster their well-being and resilience in normal times often aren't available to people. So we have to think holistically about talking about these groups as experiencing the pandemic, both as frontline workers and as citizens as well. So I'll jump on, Paula.
Yeah.
So then this is comparing those three groups that Paula described. So those people self-identifying as those not impacted by COVID-19, those impacted but not significantly versus those overwhelmed. And here you see probably the biggest differential in any set of groups. So people identifying as that in that overwhelmed group are almost, are more than a point on the scale lower than the middle group who say they're impacted and not significantly. So that adding that question to the survey this time around, based on what people told us the first time, has is proving to be to be quite helpful and illuminating in terms of identifying and then describing that group, which, remember, represented about half of the respondents who feel really overwhelmed. So it's going to be really important for us to dig into the experiences, given that that group's well-being is really suffering. So there's a bit of a difference then between people who have line manager responsibilities and those who don't, with folks who are line managers scoring slightly higher on well-being on average. However, I'd say that differential isn't as great as we might have expected it to be, based on some of the text responses that we were getting about, there's a lot of discourse that we'll be describing in the report around communication and disconnection and empathy across different levels of organizations. And I think, it's worth thinking about this, you know, we have to think about this in a multi-level systemic way, and realize that, you know, line managers who are themselves, you know, feeling overwhelmed and stressed, that will, you know, that will have knock-on effects on the people whom they're line managing. So, you know, a way of managing, you know, thinking about managing demands has to be a whole organization, a whole systemic and multi-level approach. And, you know, restoring, I think it's from the narratives we see, there's a lot of erosion of just the levels of empathy between those different groups and those different roles within organizations. A widespread sense that the pressures at the front line aren't fully acknowledged further up, and it's possible that some line managers would say the same, that they don't, you know, necessarily feel the staff fully acknowledge the pressures that they're under. So some way to build up that empathy will need to be looked at as we sort of rebuild from this period we've all lived through. Go ahead, Paula.
Yeah.
I have seen your question, Sean. I think we're going to collate the questions at the end, but yeah, if we don't remember to come back to that, do remind me. Okay, so then we get into quality of working life. So this is more specific than well-being. This is the sort of what people get out of their jobs in terms of satisfaction and sense of fulfillment and direction in life. And here again, we're seeing, we're seeing declines from the first period where we surveyed. In this instance, so yeah, there's an overall decline of about 78 to under 76 on this scale, with the biggest declines in this instance coming from in the nursing area, and not as great a decline, but still a notable and significant one in social care and social work, also having a quite a notable decline. Allied, something important to note from this slide is that the ordering hasn't really changed from one to another. If you look at which groups are the most have the most quality working life, you know, the allied health professionals had the highest score in the first, and they've also had the least severe decline from one to another. So the inequalities within the system are growing, as well as the absolute numbers moving all in the same direction, but the degree to which they are is in the same order in which the original scores were. So so that's something to be very, you know, because all of these services to a greater or lesser extent interface with one another. So it goes back to that empathy story about if the impact of what's happening on the front line is disproportionately affecting one group and not the other, less so than the other. That's particularly difficult when all of those groups are experiencing some degree of decline in well-being and stress. We do break that down further. There is that this scale brings together an array of subdomains from stress to general well-being to sort of homework interface. And again, you see them, much as you saw with the positive coping and the negative coping, sort of all going in the same direction. Again, you see all of these subdomains going in the same direction, but to greater and lesser degrees. So stress, so we see a notable increase in reports of work stress, and what we call sort of general well-being, so just sort of affect or general mood, being that's the biggest driver of these declines, but still still some level of decline in all of the other components of quality of working life. So then we come to burnout. So the way we've measured burnout is across 3 domains. So there's personal, work related, and client related. Now, the first big message that comes from this this graph and this overview is that in a normal survey or in a normal time, it would be very unusual to see such a differential between the domains. So you'd usually have them, you know, across the literature, you see them clustered in between sort of 30 and 50. Client burnout is often the lowest set of scores. So the degree to which people feel burnt out by the actual work, their actual interaction with their client group is, you know, so there's some notable exceptions like say, so prison officers would usually scale higher on that compared to the other two. But for it to be like half the level of the work-related and personal burnout is very unusual. So there's a very important message that we're taking from this, which is that, you know, to an extent, and again, I'm cross-referencing to things that I've read from participants where people are saying that the interaction with their clients is often sort of the best part of the day. Like the work isn't any less rewarding than it was. It's the volume of it. It's the job rather than the work. It's the amount that there is, the level of the demands, and even where work is getting harder or where there are novel challenges for client groups, you can still see in people's responses that the passion for delivering in the face of those demands still endures. But the overall work-related burnout and the sense of personal burnout, those are well above what you would expect in any kind of normal occupational group. And again, we see, even though they all look to be at quite high levels, you see fairly notable differentials between occupations. So again, you see allied health professionals lowest on all 3 scores relative to the others. And for client-related burnout, it's the social work, it seems, is kind of the outlier. It's significantly above the others, with the others sort of clustered in around 25. And again, cross-referencing, I mean, one might expect that the type of case mix and the type of scenario and particularly encounters with domestic violence could be driving that client-related burnout up for social workers. So that's something we need to be really aware of. I'm just sorry. I've just, you might have heard a strange voice 1 second ago there. I'm just going to mute while because I can't hear incoming audio now. So 1 second. So I should, if anyone needs to shout and interrupt me, I can hear you again now. Okay. Yeah, Paul, do you need to jump in at any point? And
no, just to say that is that client-related burnout, that, you know, it's sort of echoing what we're finding in qualitative responses as well about concern for service users. You know, there's this kind of altruism is coming through, you know, so that actually ties in very well to what we are already finding when we're doing the analysis across the qualitative responses as well. So, you know, it's, I suppose there's integrity, that's what I'm trying to say, between what we're reporting here and what the qualitative data is saying too. But that's all with a personal cost. So, you know, we can be compassionate. Of course, we need to be compassionate. And, you know, we need to have empathy at that level for the service user, but at what cost to the workforce, just in terms of their own well-being, we need to think about, well, how do we help them to stay well while providing this empathic service and level of compassion, you know, for the service users, because there's is an impact on their overall work-related burnout and their personal life burnout. And yet this, you know, level of client-related burnout is in a stark contrast to that.
Yeah, we should say as well, I mean, every thing we've sort of talked about so far is some kind of an average, and that can mask, there is obviously huge diversity of experience, and people are experiencing the impact of the pandemic in lots of different ways. And again, one of the things that's coming through is that, you know, it's a diverse workforce as well. Like the underlying workforce and the circumstances from which people perform roles like social care are, you know, are diverse. And some of the mechanisms, some of the organization, you know, if you happen to be at a previous seminar, you know, Paul and I might have been talking about aging and some of the mechanisms and policies that can start being activated around flexible working and so on. It's coming through that in a lot of circumstances, some of those mechanisms or some of those policies are either sort of on pause in their development, or they're not being promoted as heavily, or it's just not considered urgent. So some of the ways that as a workforce we were starting to come to terms with diversity of circumstance, some of those accommodations aren't as present as they were before. So yeah, that's just another sort of contextual note, just to say, like, we're aware these represent, there are a lot of different drivers representing these different metrics, and it sounds like we keep saying the same, you know, like it's all going the same way. But yeah, it's, as I say, the richness in what people have told us across the survey does help us to contextualize and give a lot of example and color to what's driving that. So yeah, so this is again in comparing those three groups. That question that we said was quite telling in terms of the differential between. So again, we just see this huge differential in, firstly, in work-related burnout, just a huge differential between people who self-describe as overwhelmed versus people who just self-describe as impacted but not significantly. Then yeah, similarly in all three domains, in the personal burnout, and the client-related burnout. And again, in terms of like trying to unpack, like, why is the difference so much bigger for the people who self-describe as overwhelmed versus those who say that they're impacted but not significantly? Again, there seems to be there's a big narrative emerging about sort of team functioning, team adaptation, innovation on the job, and sort of team solidarity and mutual support. So where there's lots of instances of good practice where people are acknowledging impacts on what they can do, what they can deliver on themselves, and trying to cope and deal with that as a team. And then there are teams and circumstances where it's really stretched the team and pulled the team apart and really eroded that solidarity. So yeah, we will be highlighting that, like, there, you know, the narrative that everyone is affected has some truth to it, but the narrative that everyone is affected equally is something we would strongly challenge and say that there are a lot of different circumstances and day-to-day contexts in which people are and some of those are very adaptive and very functional, and some of them are less so, and that's having an impact on the individuals in those circumstances. So me passing back to Paula again.
Yeah, thank you, John.
Do you want me to take Sean's question really quickly, Paula, just since I
Yeah,
come up on
that's
the
great.
chat? So Sean just asked, did the time of year that the survey covered impact on the stats that were gathered, i.e. the first one was in spring, summer, brighter, warmer. You would see seasonal, slight seasonal effects on the likes of Wellbeing, but on average, it wouldn't ever average out to like a point on that scale. So you I mean you're probably you look, it's a kind of an interesting empirical question of like how much worse has lockdown 2 or 3 or 4.5 or whatever we're on to now been because of the time of year. The historical fact is it has happened at this time of year. We're just reporting out in the historical sequence in which it happened. I would say that the ability, from what people are telling us, the ability to use the outdoors for exercise, a degree of socializing, and the first survey did take place in us against the backdrop of slowly relaxing lockdown measures. That there probably will have been some seasonal contribution to that, but I think maybe the failure to put a lot in place after lockdown 1 to mitigate against the effects of the second wave, I think are the bigger story, not to be underplayed too much. But yeah, sorry, since that was kind of a statsy question, I thought it would just take that one in the flow. But yeah, I think we'll maybe take the other questions together at the end.
Yeah, that's great. Thank you, John. So emerging from the first survey point, we crystallized the findings overall that included the richness of the qualitative data to make good practice recommendations. And so these are some of those. Basically, what we're doing now, we're revisiting those to see, are they all still current? Are there any redundant? Are there any new recommendations emerging? So we are literally right in the middle of doing all of that at the moment. So I'm going to just share with you some just initial thoughts that we think are going to be remain within the good practice recommendations. And first of all, it's about flexibility and around working hours and location, including working from home. So I think between the first data collection point and the second, I'm hearing, and what is being, shared in the data is that employers did get better at that bubble, working the social distance and having teams working back to back and flexible hours, but I suppose it's the continuation if that is required. So we thought this one's an important one to remain as a recommendation, to have that kind of level of flexibility about working from home if it was possible to work from home. Of course, not all professions have that luxury about being able to work from home. So it's very profession specific. Clear and relevant communication needed. So especially at the very beginning when government guidelines were changing all the time, people felt overwhelmed with information, just, email overload, and some reported getting sent everything and told to interpret it, as opposed to having guidance. So there was a recommendation that, information needs to be relevant to the profession that it's shared with. There was examples of it being, irrelevant across both surveys. Some staff are keen for more involvement in decision making and autonomy. So this was about speed of decision making at the time of crisis, and sometimes decisions having to go through a couple of layers of management. And staff felt that in a crisis situation, and it being a pandemic, that maybe flatter hierarchies should be part of that crisis response. Connection with colleagues and managers. So if people felt connected, and that could have been virtually using Teams or Zoom or WhatsApp or, other virtual ways, If they felt connected, their well-being was positively impacted. If they felt disconnected from colleagues and managers, it was negatively impacted. So people talked about feeling isolated, and how that really increased their anxieties. That loss of, the team and camaraderie and support. Visibility of management, either in person or virtually. So for people that saw their manager more proactively, that positively impacted on their well-being at work. For some people, they weren't getting that, and this became one of the recommendations, just that management realised the impact that their visibility or invisibility can have on the workforce. Staff altruistic concerns for patient well-being. So there was some feedback from the qualitative responses about, that they didn't feel always listened to, about, risks of viral spread, concerns that were being raised. They felt that sometimes stressed out managers were trying to silence people about genuine altruistic concerns about patient well-being. Now moving forward, staff well-being focus needs to be part of a structured plan, short-term, medium-term and longer term. And that is in relation to the prolonged levels of stress that people have been exposed to. And so some type of organizational response would be needed to target people specifically, but to provide more universally a range of different well-being resources for the workforce, including, and this is one of the final points in the next slide, but I'm going to jump to it, including well-being and taking their leave. So because of the crisis situation and people been off, people were asked not to take annual leave. And they were exhausted, and for some it meant them taking sick leave. They became unwell. So it's that trying to get back to a place where people are taking regular breaks and taking their leave. The first point in this slide is about redeployment. So when we measured redeployment in terms of doing the statistical analysis, we found that basically people's well-being and quality of work and life were negatively affected by redeployment if they weren't prepared for it. If they were prepared for it, if there was some level of preparation and skills training, that they did better in terms of their well-being and quality of work and life. There was some issues around fairness and rules about working from home as well. And some of the responses were making reference to managers working from home and being in a luxurious position compared to people that were out doing, the frontline work is the way they saw it. So there was some criticism about that in terms of fairness. And that was related to the point about invisibility of management as well. Connectivity, of course, it was a particular issue in the first survey. It was less notable in the current survey. But so it's just, I suppose, one of those things again around the whole inequalities John was making reference to previously. Things like having a poor internet or, not access to the internet. It makes all the difference to somebody that's trying to stay connected with their colleagues at work. General health and safety at work. So this is about people sharing workspaces and equipment. And, for some, there was not enough actual space for proper social distancing, and they did feel at risk. And basic things like hand washing and sanitizers being present. So it's that basic health and safety for the workforce, and that extended, of course, to PPE in a big way whenever it was the first survey point. At this point now, there's less coming through in the data about PPE being an ongoing issue so far. So we're working our way through 3,500 responses to questions, but that one doesn't seem to be jumping out this time. Statutory sick pay, for some, they were taking risks about going to work, sometimes with symptoms, because they only got statutory sick pay, or some didn't even get statutory sick pay. So that economics, that financial inequality as well, and poor working conditions and terms and conditions, in particular, this was notable for the social care workforce, that it's a very important one going forward, and how that is mitigated against. And I do think there is some government intervention around this now, so it is probably improved since the first survey. So that is the end of the presentation in terms of those good practice recommendations. This slide is just, our funder is the PHA, and also we have support from the National Institute for Health Research, but we just particularly want to really thank all the people that took the time. It was about 25 minutes, I think it took, to complete the survey, but to complete the survey while their working conditions were what they were, and continue to be what they are. I think we're coming down the hill a bit, but there is an aftermath after an emergency period like that. The other work has to keep going on. And these are workforces that are under pressure in non-pandemic periods. So there's a specific, level of pressure that's on them now. And so what we'll be working on is sharpening up those good practice recommendations, just to share and provide a voice to those people that have participated in this survey. There's a link here to a website, and we have like the first report and executive summary and publications, and all information about this study is in there. So you're very welcome to have a look around and email us if there's any questions, or if you're interested in participating in one of our focus groups as a frontline worker or a manager, we would be delighted to hear from you. So that's all from me, Paul, unless there's any questions now that we could maybe speak to.
Sorry, I realised I was on mute there. Thank you very much. That was a really interesting, fascinating range of results there this morning. And I suppose there was a few questions came in on the chat, which we could maybe try and sort of deal with now. In terms of the thing I was interested in, I suppose, particularly was the differential between social care and social work. And I was wondering around the resilience piece. A lot of our social care staff have been out there on the front line over the period, and I was just, I know it's more difficult for social work in a sense in terms of accessing people, and I was just wondering in terms of the people who had their job necessitated practical support, was there anything coming through around that in terms of how the impact between the other health professionals and the social care people? I don't know if there's anything you would want to respond on that.
Yeah, so the acute sector, they had a particular set of responses that were based on clinical insights and concerns for patients at hospital, and ensuring that their own well-being in terms of not picking up the virus and not bringing it home, that was very much a concern. For the social care workforce, they felt there was a lot of narrative about not being valued, not being seen. Some were saying, it's good that we're finally getting some recognition, but they didn't feel the clap for carers was for them, for example, in the first survey. So any kind of resilience, if you want, that, or well-being, came from how they were connected with peers, their concerns and compassion for the service user, and really, talking about how, they were really concerned about, say, for example, there was a CAMHS social work response that talked about, worrying about young people not getting the support that they need, young people not engaging in online services, and worrying about, them ending their lives because the supports that they would normally come for weren't there, and they had to use online methods, and young people weren't responding to that. And then there was a social care worker that talked about just watching the decline in older people in a nursing home because of being, not able to see loved ones, and that whole social distancing impact. So, some really heart-wrenching accounts of the work and that emotional labor, and, the emotional exhaustion that was coming through as well, that would have been my kind of pieces of insight, Paul.
That's great. Thank you very much, Paul. There was just another question there from Susie Morrow around newly qualified staff. Susie, do you want to take that question?
Hello, Paul. I don't know if I can speak. I'm on a shared screen. Can you hear me?
Yes, we can hear you.
Yeah, so no, I work with AYE students in social work, or sorry, AYE staff in social work, and we've noticed such a difference between AYE staff's experience of working from home and that of older, more qualified staff who are comfortable with their role, and just the loss of learning and the loss of support for newly qualified staff, also I suppose for students. I wondered if the survey had been able to pick that up, or was it not able to differentiate between the length of time that staff had been in post?
What we did was we asked about your years of experience, and so I think our first block is less than 2 years. So that would be captured to some extent, the first couple of years after qualifying. So we would be able to drill into that. We will, in the full report, and it's, it's like nearly 300 pages already, and we're not finished. But that is, the appendices are full of all the figures and tables with that breakdown across age bands, gender, ethnicity, all the results across all those scales that we used. So and we're doing a section that is raw data and a section that is weighted for country and weighted for professional group, because as you can see, there's that disparity in numbers, about how many participated. So there's a statistical method that John is expert on, that he has used to weight the data to make sure, that what we're comparing is, it's been thoroughly analysed in terms of the numbers. So that available is my answer to you. And whenever the report is available, it'll be available on that website there, or if anybody wants to email, we'll get the report out, but we will be disseminating it widely. So you're welcome to dig in or ask any questions. The data can produce questions that we haven't answered yet, so if there was something specific, that employers or social care council or others, wanted to ask, we could turn out that response.
Thank you very much, Paul. I think there's a few more. I think Rachel has a question as well. Rachel Naylor, do you want to ask the question to the panel?
Yeah, I think actually Paul has just answered it, because I was just asking whether there was enough of a gender balance in the sample to do a gender analysis. Just thinking about, there's obviously often gender differences in coping. But I think Paula's saying that there is, and also I was asking about data in terms of ethnicity. Paula also mentioned that's available. So I think my question's answered already. Thanks.
Okay. I think, Leila, you have a question as well for the panel.
Yeah, hi, how are you?
Good, thank you.
Hi, yeah. So I'm a
Hello.
Central St. Martin's student and I'm studying graphic design, and I'm working with two students. They're also on the call, and we're collaborating with NISCC, and we had a talk with one of your colleagues the other week, and we need to come up with a strategy to help younger people, specifically aged 18 to 24, to start working in social care. And we wanted to ask if you already have a strategy that's more specified to younger people.
Is that a question, Dinesh?
Sorry?
Is that a question to Paul?
Either. Whoever, if anyone has an answer, if there's a specific way you kind of market or target younger people to start getting into social care.
Yes, Leila, well, we're doing a lot of work at the moment around, one of the big issues, I suppose, within social care at the minute is a parity of esteem in terms of other professionals working in health and social care. So, you know, we have a very sort of robust plan ahead around, particularly around the value of social care and what it brings to the system. And I think COVID has really outlined the importance of social care within our society. And you just have to look at some countries during COVID, Italy particularly, where people died because the workforce walked off the floor. So there's a real, I think, a better understanding of the important role that all our health professionals and social care professionals play, but particularly social care. The recruitment around, young people into social care is really important. Our workforce at the minute predominantly is women. It is age 35 to 54. We have to plan for the future to develop a more diverse workforce coming into social care, but also supporting our existing workforce in terms of particularly value of social care, the parity of esteem, terms and conditions, etc. And career structure within social care is really, really important. So we've been requested to start to develop proposals around what that might look like into the future. So we're working really closely with the sector, with the education side of things in terms of qualifications. And there's no quick fix really, because if you look at the strategic documents carried out right across the United Kingdom in the last 10, 15 years, it continually talks about the importance of investment in social care, investment in developing career structures, recruitment, retention, and it's a very value-based workforce, and we need to attract the right people into that workforce, and we need to support and maintain them when we have them there. So there's no easy answers to this. It is dependent on resources, it's dependent on investment, and most importantly, I think the parity of esteem issue across, we need to work towards bringing social care out from the periphery to other professionals and much more into a more integrated part of our whole system. And there is a big voice in social care to be heard, never mind research. So your point's well made.
Yeah, so do you have a lot of like young people working in social care, or is it mainly older?
No, well, we do have young people coming into social care. Do we have enough to plug the gap in the future? I think not. So the work that needs to develop needs to attract young people into social care, and social care is a difficult workforce in as much as it covers such a broad spectrum in our community, from addictions to mental health to learning disability, sensory services, but often people perceive it as very much older people's services, nursing home, personal care. So there's a bit of a journey to be done around articulating what can be achieved through a career in social care and how we support and develop that workforce right across. It is a diverse workforce. It's not like, you can focus on a social worker or a nurse. People understand what those professionals do. They understand the structures and the career opportunities for them, less so in social care. So there's a lot of work to do across all the sectors to encourage young people into social care.
Yeah, hopefully we can try to find a strategy to do that.
Well, there's a whole range of strategies and proposals needed to take this forward, but it's very, very important because we all need to be supported.
Yeah, of course.
Absolutely. Thank you for that.
Can I just jump in on that, because I think that the need for acknowledgement, as Paul has said, came through really strongly in the data from social care workers, and something I think we'll be pushing for very strongly in the report, like for a very kind of meaningful and in-depth campaign of acknowledgement and recognition. And I think in terms of the work you're talking about doing, Leila, I think really narrating this as as a year in which social care sector like kind of stood up and was counted and was were part of the kind of frontline heroes that were needed at the time. I think that will be an important message to people who are considering, and again, going back to the diversity, like Paul's mentioning, the many different contexts in which people's work and passion was really needed. I think that's part of what's the driver for acknowledgement at this moment, is an eye to the future, an eye to stimulating future engagements.
Yeah, for sure. Thank you.
Thank you for that. I think Alison also had posed a question around personal burnout. Alison, what do you want to raise that?
I can read out Alison's question if you're there.
Yeah.
So Alison was saying just about wondering about personal burnout. Was there any indication those who were trying to juggle work demand with childcare issues and homeschooling? So we did ask about caring responsibilities. So we haven't broken down the numbers by that on that axis for you for today's presentation. We asked about, of course, there's sort of the back to the kind of sandwich generation analysis of caring responsibilities for older people as well as childcare responsibilities. A lot of people were discussing that pressure in different contexts. Some people were saying that that it was good that their frontline work status was acknowledged and that schools were kept open and there were facilities. That didn't obviously apply to everybody. I mean, some people who were working from home potentially could have availed of that and chose not to, because it might have differentiated themselves and their work because they were technically doing it at home from frontline people who were working in the normal place of work. So I think there's something to be reflected on in terms of how clear that guidance was for people as to what they were entitled to from the school system in terms of relief. That was the first thing that came to my mind when I saw your question. Paula, did you want to?
Yeah, no, that's helpful. Paula?
Yeah, so I was just going to say that like 1 and 2, I think, out of this current survey, and I think social work, John, maybe you'll remember this, there was like 70% said that their caring responsibility changed because of the pandemic at the first survey point. So, that was like quite overwhelming for people. You've got your job and your caring responsibilities changing rapidly, between homeschooling or caring for older adults. There was a range of different levels of impact, and that would, of course, impact on people's personal life, personal burnout, therefore. Yeah.
Just a question about did the survey cover in relation to people's digital skills and digital capacity? Because clearly we're all dealing with less paper, but not everybody, and it's not necessarily a generational thing, but not everybody is digitally enabled. Did those issues come up in the survey?
Do you want me to take that, John?
Yeah, go ahead. Yeah.
So the first survey, it would have been more about not having, you know, like a good internet connection, not having the right tech equipment. You know, there was somebody, I remember somebody made reference to like working off a phone or working off a tablet, you know, it taken so long for the employer to be able to get them the right equipment. For some, that happened more rapidly. So there was variations again, you know, in how that was managed. This survey, there is less prominence of that coming through. I don't know, John, if you want to say something about your analysis of the qual data. It hasn't come my way that this was a major issue now at the second point.
Yeah, I mean, it's, as I say, I'd be more kind of drawn from my sort of yeah, my general work on digital divides, as you say, like you know, where you have a lot of, you know, nationally there's been a lot of studies where, you know, there's people there's households where there's, you know, one really workable internet device between, you know, people working plus people plus younger people needing to access it for education, and where people are taking a turnabout. So yeah, it's the resource side of it is something to be really aware of. There were a couple of comments around sort of client related equipment and the you know, some of that falling out of date during this period, and updating and procurement being delayed and slowed, and installation having been curtailed. So but I think undoubtedly, like, I think exactly like as you say, as you're observing, you know, it's back to the diversity thing. Is like people are coming from different baselines, and yeah, it's going to be a big part of the rebuilding period that comes now, that people don't feel like they've fallen behind, or that they've kind of fallen out of favor within their teams or whatever, because of you know, because of either barriers on the resource side to technical connection, or because of digital literacy. I think digital literacy is, you know, is an omnipresent, you know, global priority, and something we shouldn't take our eye off as something that, you know, the areas of the sector that had invested in digital literacy before the pandemic will probably have evaded that set of issues, and those that had been putting it on the long finger, you know, just as in education, where we've seen, you know, where there were really active, those who were really active trying to engage with multi-platform learning, you know, were able to adapt, you know, a lot more quickly and a lot less stressfully than areas where that hadn't happened.
Thank you for that. Is there any further questions before we end this morning's seminar, lunchtime seminar? No, happy enough. Just to raise some awareness around some of the resources. People asked earlier on around resources about supporting the workforce, and on our learning zone we have been really busy all year trying to develop with the sectors, with professionals, resources that will support, and we have the resilience of well-being for social care workers online, hopes, hints, and how to help you respond to living and dying issues during COVID-19. A lot of the shielding work. There's ongoing work, I suppose, with our sector at the minute around further supports to our workforce. We have the apps on the learning zone here around the library for mental health and well-being, and I would ask people to click in and just find out a wee bit more around what is available to support people during this particularly difficult time. And you can follow us on NISC Social Care Council, and if there's any further information you need, please don't hesitate to come back to us. We have a continual amount of resources coming through, and take the point from Paula earlier that people have been inundated with with information during the last year. It's been really, really difficult, but also at the same time, it's been really helpful to update people, particularly around infection control, things that really are pertinent and are changing all the time. So look, thank you very much to both our speakers this morning for taking the time out. I know you're both really busy. And
Paul, there's just a question just come in there on the chat, sorry.
Yeah, I'm happy to take that.
From Patricia McKeever.
Yeah, Patricia, do you want to?
Sorry, Paul. My internet connection is quite weak, so I'm just wondering. Some services have actually experienced a major reduction in referrals and work capacities. I mean, I'm just looking at some of the child protection issues, referrals, mental health referrals, and domestic abuse, sexual abuse, and alcohol abuse has all increased during the pandemic if you look at police statistics. And given our social work staffing issues in Northern Ireland in terms of our current output of social workers, I'm just wondering, is there any plan, because I think lots of services are anticipating a massive upsurge when we come out post-pandemic. So I'm just wondering, is there any of the information being used from the survey being used to plan for that?
I'm happy to take some of that question. I think, Patricia, COVID has been a huge learn for everyone in society, but particularly I think within health and social care, and certainly different sectors within health have been working in the background around rapid learning, around how do we very quickly and with agility move forward in terms of learning from the experiences that have happened. I think your point is well made around post-pandemic. We will be dealing with a very different issue, I think, particularly around poverty and all that brings. So I think this is not, the wave of COVID, once it ends, will bring huge challenges for our workforce and for our professionals. So I think the work that's been undergone right across around research during COVID, information has been presented this morning, has to influence and make us think around how do we support, how do we develop resilience within the workforce, how do we recruit, how do we protect people. There is learning at every stage in this pandemic. And I think professionals within the sector have to step up in terms of telling them stories. We've been doing some work with the sector around trying to hear the stories that have happened out there, the learning that's happened out there, and how we need to decide, I suppose, going forward of what learning do we want to bring further in terms of progressing. I think the other issue is that it will take a number of years for us to mop up some of these really complex issues that have emerged. And the point was made earlier, there will be potentially more pandemics, so we have to learn from this. So thank you for your question. Anybody want to add to that, Paula or John?
I would add, you would hope that the workforce review that's currently, happening for social work, will have this identified as one of the risk factors going forward, because we know already, the whole rationale for needing a workforce review was that we were having issues, retention and turnover, vacancies, and so forth. So so you would hope that it's only a coincidence because the workforce review is happening anyway, and then COVID has happened. So that's another layer of complexity, that the workforce review, I would say, will be taken account of.
Thank you.
I think
it's helpful, Patricia, just to say that our in terms of our registered workforce, in terms of who we're registering at the council, that it's now exceeded 50,000. So actually during COVID, it's actually increased quite significantly. I don't know whether that's helpful, but certainly we have seen a big increase in the number of registrants since April.
Yeah, and I think if you look across the United Kingdom at the minute, that we've been talking about investing in social care for many, many years, because you listen to the stories coming through about the perception and the reality sometimes of the broken system in the UK around how integrated social care is in terms of health. So that will really influence going forward the changes that need to be made, and also will make the case around the resources required to support and develop the social care workforce particularly. And we're having those discussions in Northern Ireland, and we're involved in a number of bids around that at the minute, around recruitment and retention, and the parity of esteem issue around the value of social care. So I think there's been ongoing learning on the hoof, as in a sense, in relation to this, because it brings in stark contrast in terms of when you get it wrong, how significant that is for citizens and for society. So a lot of work going forward, I think, in terms of particularly around workforce development and workforce strategies. I'm conscious of the time now. I'm happy to take, if there's any more questions before we finish, happy to do so. But if not, I want to thank Paula and John today for a very insightful presentation, and I wish you well in terms of disseminating that information and taking it forward in terms of your future research. So thank you.
Thanks for having me.
Thank you for the invitation.
Not at all. And take care, everybody. We will have further information coming in our next number of seminars over the next number of months. So we'll keep you informed of what's happening. So thank you for taking the time this afternoon. All the best. Bye.
Thank you.
Bye.
Bye.
Bye now.